Hello, this is Andrew Merritt again, and today we're going to talk about one of the most interesting and frankly complicated aspects of knee surgery, which is patellar instability. So patella instability is a common injury that I see in my clinic, and essentially the bottom line is, if we're looking at the knee from the front, the kneecap pops out, goes out to the side, so it doesn't stay in the middle of the knee. The reasons for this are complicated. Frankly, this video, it's going to be challenging. It's going to be complicated, but some things in life just are. So bottom line is, if it goes over your head, just come in and see me if you're dealing with this problem. Maybe this is more applicable to people that treat this or residents that are interested in this subject. But it's just, there's no way to discuss this topic without getting into the weeds a little bit. So let's get into the weeds here. So patellar instability. First of all, the patella is stabilized in the front of the knee. So here's the kneecap. It essentially connects the quad muscles down to the patellar tendon, allows us to extend our knee. It floats in the front of the knee. If you stick your knee out straight and loosen your muscles, you can feel your patella be quite mobile. So that's different than a lot of joints where they only want to move in one direction. This patella kind of floats there. And so it's a little more at risk of things like dislocation because it's pulled wherever the forces want to take it. And that's going to become a big issue or a big talking point for this. So when we look at the forces that do pull on it, the quadriceps pull is a large pull up towards the top. The quads, as the name would suggest, have four muscles. The vastus lateralis pulling out to the side, vastus medialis pulling inwards. The patella at the other end that we talked about, the patellar tendon, comes down and inserts on what we call the tibial tubercle. The stabilizing structures that are not muscles, we'll talk about all of them, and there's some bony anatomy aspects, but the medial patellofemoral ligament, or what we call the MPFL, is a check rein that allows it to move some but not too far. There's also the lateral retinaculum, which is the joint capsule on the other side that helps stabilize the kneecap, kind of allow it to go some but not too far. The problem is the net forces, so going back to high school physics here, the net forces are pulling out to the outer side. So the patella almost always, 99 point, lots of nines percent of the time, dislocates towards the outer side because the pull is all out to that side. And that's why the MPFL is quite important to act as that check rein to hold it in. So everything's pulling to the outside, the muscles, because it goes up towards your hip and the hips are broader than the knees, and then the patellar tendon inserts out to the outer side as well, and the resultant force is out to the outer side. So we got to know that for the basics. So when someone has patellar instability, they often feel similar to an ACL, a kind of a rotating or buckling injury. They collapse. They often see deformity. If they do see the kneecap out to the outer side, they will notice their knee looks very different. The kneecap is off, and the whole shape of the knee is out. If that happens, straighten the knee, it'll pop back in, maybe a little force from the outer side. I see lots of people that spent 3 hours with their patellar dislocated waiting for the ER doc to do the exact same thing. So I know there's a lot of anxiety around this, but straighten out the knee, push that back in, get it to look like the other knee. Not going to cause you any problems. That's just what the ER doctor is going to do it, and it's going to save a lot of pain. If a reduction is needed. The symptoms after that point: swelling, pain in the knee, you're going to feel weak, it's going to feel like it wants to give out because the quads are going to shut down, and there's going to be a feeling of instability in the knee joint. Initially, the treatment is to reduce the dislocation, give you some brace, some crutches, give you a brace to help stabilize the knee so that you can put weight on it and can start moving again. Usually we get x-rays and then an MRI to confirm the injury and start to see the risk factors of why this happened, and does something need to be done? Is it going to heal on its own? And we'll talk about all of that. Short term, we're going to get you into physical therapy. We're going to rest the knee, get the quads waking back up once the swelling starts going down, get the range of motion back. Generally, if it's a young patient, we get an MRI because we want to start to calculate some of these factors to see the risk of this happening again, see if there's cartilage damage. As always, we do have an urgent care at our practice, which is well versed in all of this, can get the correct brace, get the MRI ordered. Here's a QR code that leads to that page if you're interested. Often on the x-rays, it's not telling us that much, but here what we can see when we get what's called the sunrise view is a normal patella that sits in the center of the knee, and then one that's recently had a dislocation. Now the MPFL that holds it in here is torn, as happens with a patellar dislocation. You can start to see the patella tilting towards the outside. So x-rays are not the main thing here. We just tell, is it reduced? Is there a fracture? General part of the workup, but not where we're getting the majority of the information. So let's talk a little bit more about the anatomy. What keeps the patella in so that we can know why the patella doesn't stay in sometimes? So muscles and ligaments. We have good muscle control, good quad control. We talked about the vastus medialis, this inner muscle here that's helping pull towards the inside. The medial retinaculum or the medial patellofemoral ligament is helping to hold the patella inwards. Those are the main forces pulling towards the inner side, what we call medial. Everything else is pulling to the outer side. The bone anatomy is critical. We'll talk a lot about this when it comes to treatment, but essentially the shape of the patella and the trochlea, and you can see here on the model, if I can get this lined up correctly, is the trochlea has, let's see here, has a little groove and the patella fits in that groove. When we see that on MRI, we can see that the patella in a normal knee is made to fit what we call the trochlea. So this is to the outside. And so having this trochlea here means you would have to go up to go out. Okay, so that bony anatomy acts as kind of a retaining wall against the patella, just sliding out that way. So what causes instability? Well, when we dislocate, we're going to tear the MPFL. Only in super loose people would we be able to dislocate and not tear the MPFL, because the MPFL in someone with Ehlers-Danlos or really unstable kind of loosey-goosey knees, those can pop out and not tear that, but that tear will lead to or results from the first dislocation, but then can lead to subsequent instability issues. And so we again looked at the MPFL. Here's what it looks like on an MRI. A normal MPFL here, nice and tight, holding this patella against this wall, keeping the patella nice and centered. Here's a torn one after a recent trauma. You can see this white suggests white is bleeding or swelling. There's lots of swelling in the knee joint you see here. And then here's the MPFL coming up, but not attaching to the inner side of the kneecap. So often that separates there. It can also separate down off of the femur, one side or the other, often the patella, and it separates off. That's what an MPFL tear looks like. That can actually heal, and so we can we talk about that as a potential option of healing. When it gets to surgery time, we do MPFL reconstructions and essentially remake that ligament. We use a triangular based ligament where we go down into the femur and bring up two limbs. I often tell patients this is one of the few reconstructions that we do where the ligament we put in is actually stronger than the ligament that was there originally. So this is quite powerful. A lot of times this is enough, or in coordination with a lateral lengthening that we'll talk about in a second, to hold the patella in, because this is a pretty strong band of tissue we're able to put in there. And again, it's just a check rein. We allow the patella to move a little, but not too far. So it has some mobility, but doesn't pop out. With this often comes what we call a lateral lengthening. So when we look at the time of a knee surgery, we'll often see the kneecap where it's tight over here and there's lots of space here. That should sit equally. That means that we're tight on the outside And since we're torn on the inside. So here we see that here's a torn MPFL, it's not connected. And then look how bowstring tight this outer retinaculum is. So it's leaning, it's pulling more to the outside. So we give that a little more space on the outside, allow that kneecap to sit back in the center, and then do that reconstruction. Essentially, the way it's done is by dividing these two layers and suturing it back so that it's lengthened, so that the lateral retinaculum is lengthened. They used to do lateral releases. I haven't done one in over a decade, where we just cut that tissue and let it be, but we can be much more precise when we suture it back together of the exact length that we want that at. And that's called the lateral lengthening. And it's rarely used alone, definitely not for patellar instability. For some other pain problems, we can use it as an isolated procedure, but generally this is mixed in with the other options that we're going to talk about. So that covers the MPFL tears. Now, what about the bony anatomy? So this is a big thing. Not all knees are built equally. In fact, there is a lot of variability in the patella, and especially the trochlea, the groove that it sits in. So let's look at some of those. So a normal trochlea has this nice groove that we talked about here on the left-hand side where they sit in. That is very hard to dislocate if we have a nice groove. If we have a flat groove or a shallow groove, or especially if we start getting into these higher levels of what we call trochlear dysplasia or malformed trochleas, we really start to risk dislocations. The normal trochlea that we see here, again, has this nice shape and groove. And then as we go towards dysplasia, we can see this patient here has had hundreds of dislocations. Their groove is essentially non-existent here. So what happens is the kneecap sits off to the outside here. So this is much more likely to cause instability of the patella and dislocation because there is no groove holding this in. We call this trochlea dysplasia. So surgery for this can be done to deepen the groove. We call this a trochleoplasty. So we undercut the patella, lift up the cartilage here, and then we can actually deepen the bony structure, deepen the groove, and settle that cartilage back in. It's quite a big procedure for people, but by suturing down this groove, we can go from a flat groove down to remaking that groove, something we call a trochleoplasty. This is, sorry, I should have warned you, there's some surgical images coming up here. So what we see here are a before, during, and after picture of surgery. So it's kind of hard to see, but this on this top corner here is a very flat trochlea and a big bump. So essentially, where there's a groove, like down deep here, should continue to be a groove up at the top here, and it's completely flat. So we lift up the cartilage, excavate out the bone there to make that groove, and then suture that back down. And I think you can see on these sutures here, there's now a nice groove to track that patella again. So the other thing with the anatomy of the knee that comes into place is the location and length of the patellar tendon. So the patella, again, sits in the middle of the knee and it's pulled by the direction of the patellar tendon. And the variability of where that tibial tubercle can come in, and we can measure this on MRI. Some people it pulls directly in line. Most people it pulls a little to the outside. In some people it can pull very far to the outside. As that moves over, that resultant force that we talked about moves that over as well. So there's a higher pull to the outer side. This can also be combined with the height of the patella, what we call patella alta or patella baja. Patella alta is when it's too high, and the problem with that is that the patella, when in full extension, comes completely out of the groove. And if it's completely out of the groove, then when you go to start flexing, it can choose, does it want to go down the groove or does it want to go out of the groove? And so we can see a normal patellar height where there is some overlap between the end of the patella and the top of the trochlea, or where there's no overlap at all, the patella actually sits above it. That provides a lot more risk of instability. The result, or we can measure that on X-ray or on MRI, in the X-ray, we take this measurement of the length of the patella to the patellar height, and that can tell us how high that is. We also see that on MRI on that overlap that I talked about. The result of both these is that we can control this by changing where that tibial tubercle is located. We can lower it or we can move it more to the inside. That's called a tibial tubercle osteotomy. So surgical pictures again here, what we have is the patella sitting centered in the groove. This is before surgery, and you can see on this left hand getting pulled over to the outside to the tibial tubercle here. And we can shift that over, and if needed, shift that downwards. Here you can see the amount that we moved it over, and now we're pulling much more in line. The pen's not really showing up because it's red here, but we can see the purple lines pulling much more in line after the surgery. So now the patella is going to be pulled less off to the side. We can also correct that height. Here's a patient where we did correct that height, and I drew this line from the back of the this line in the femur called Blumenstadt's line, done on both sides, and you can see the patella is sunk down about 1 centimeter. It's not often a big correction. It's just enough to get that patella so it's engaging the trochlea at the start of flexion. So just by pulling that down, usually 1 centimeter or less starts to cause that engagement. And so this is someone who got moved over as well as down. You can see that on the X-ray, pulling that patella distally there, distally meaning further down. We can also do this without moving that tibial tubercle. We can move it down by a patellar tendon imbrication, where essentially we just make the patellar tendon less long so that that has the same effect of pulling that down. Rotation, the leg rotation also plays into how the patella is presented to the trochlea. This happens in both what we call coronal alignment as well as rotational alignment. So we've all seen different people that are either neutral, what we call varus or bow-legged, or knock-kneed. We're going to talk mostly about this valgus or knock-kneed look. They have a higher risk of patellar instability for the following reasons. Again, it's about that vector to the outside. So in a normal alignment knee, someone who, their lower limb alignment is what we consider normal, has that little bit of vector to the outside. That has to do with the quad pull and then the tibial tubercle. If we have a more knock-kneed alignment, we can obviously see that that's going to increase the vector to the outside. So certain things can be done to correct that alignment. That indirectly changes that tibial tubercle location and the pull on the patella. We call that either a distal femoral or a high tibial osteotomy to correct that alignment and get the patella tracking better. Rotational alignment also factors in here. Essentially up at the hip, the rotation on the lower limb from the hip influences the knee down, and what we call femoral anteversion. And it's easier to see from the top here. If we have too much femoral anteversion, so the femur points more forward, these are people that will often say they trip over their feet, especially as a kid, or they're pigeon-toed, because in order to get the hip to feel better and be in normal alignment, the foot faces inwards. And what does that do? Well, more forces are pulling the patella out to the outside. It's complicated, but essentially, if we have increased rotation, the trochlea is facing more inwards, but the pull of the patella is still outwards. It's going to want to encourage that knee to find the patella to find the shortest line from the hip down to the foot, which is outside of the rotation on the femur, or outside of the trochlea, thus a patellar dislocation. So it's complicated, but we can get a CT scan and measure this, and if needed, derotate the femur and fix it so that the trochlea is again presenting better for the patella. This is called a derotational osteotomy. The last thing, and probably most important, is previous dislocations. So once someone's had a dislocation, they're at a much higher risk of having additional dislocations. This was, many studies have been done to look at this, and it's all about the risk factors, okay? So what are the risk factors? Young age, skeletal immaturity. This de jour classification is the trochlear dysplasia. And then this is where the tibial tubercle is, essentially the way of measuring how far over that tibial tubercle is. Depending on the number of risk factors for that, our risk of a subsequent dislocation goes up to the point that if you have 4 of the 5 of these, there's a 80–90% chance you're going to have additional dislocations, especially if we're young, especially if we return to cutting and pivoting sports. So once we get the information from the MRI, once we meet in clinic and we can evaluate the leg rotation, trochlear dysplasia, all of these factors, we can start to predict how frequent or how common it is going to be to have another dislocation. And this factors into our surgery discussion, because there are certain times where we dislocate the patient, the patella, a 40-year-old male, traumatic dislocation, something hit their knee, it dislocated, no risk factors, no surgery is needed. They're not going to have another dislocation. Contrast that with a 14-year-old that's had 50 dislocations already, has abnormal rotation, trochlear dysplasia, still not done growing, wants to return to soccer. Well, they're going to essentially have a 100% chance of recurrent dislocations. And the amount of surgery that is needed, either just an MPFL reconstruction, maybe some bony work, having to start to move the tubercle, doing some osteotomies, the punishment fits the crime. Essentially, if there's not that much wrong, we generally have to do nothing or something small. If there's a lot of anatomical factors, we have to do something more significant. So a lot of this is just the discussion. That's why it's complicated. That's why for me it's kind of fun. Figuring this out, figuring out the puzzle. It's always different for each patient. What we decide is the right course of action. So it's not easy. It's a complicated talk. Probably, I know when I finished residency, I didn't hardly understand any of this. And now, since I deal with this all the time, it's started to become routine, but it's still complicated and provides us a challenge. So if you're going through this, or your child is going through having some patellar instability and would like to discuss different options, please give us a call. This is something that I talk about all the time, and I love having this conversation. And frankly, very successful with surgical treatments here. So please give us a call if you have any questions, and thanks for watching this video.